Thank you. I'm Representative Dara Torrey from the Washington 2 District, and I'm one of the co-chairs of this wonderful Public Health Caucus that we just started up last year. And I'm really excited to have Professor Pam Berenbaum with us today, and we're going to learn some great stuff together. So I just wanted to say briefly that I'm on the Environment and Digital Infrastructure Committee. Been very drawn to public health as a climate champion, and very concerned that we have a forum to understand how all of our work on all our committees really intersects with public health. Learn how to best advocate for health of Vermonters.
And I'm Kate Yearson. I'm a representative from South Burlington, and I helped start this caucus last year. I work in an applied public health field. It's not my education by trade, and I'm very enamored of it as a decision-making and problem-solving tool, and how it's very methodical and considers the long-term costs, which I think could be very helpful as we make decisions at the legislature, looking at that more, especially with a lot of these seemingly intransient, these intractable problems that I think require some of that thinking. So thank you. And I am going to introduce our other steering committee folks, and then they can say a little word. So I'll pass it off to you, Esme.
Hey, everybody. Thank you for coming. The first of the year. Very exciting. I'm Rep. Esme Cole. I represent Hartford, and I became interested in public health for similar reasons, but a lot of the underlying systemic problems we face, I think we tend to face them when they get really bad. And I love that public health is a way to address those before they get really bad. I did a little work with the Vermont Department of Health, and that got me exposed to the area. And I think we could do a little bit more public health integration philosophy in our legislature. So I'm excited that this now exists. And Leslie?
So I'm Leslie Goldman, one of the founding steering committee members from last year. Our tagline was through the lens of public health. The idea being that everything we do has this public health lens, because everything we do does affect the health of the public. And I think we need to really be conscious of that and think about how to improve the health of our population, which would then, of course, have lots of downstream benefits. So we want to move upstream and see how we can do that and have a healthier population in Vermont.
Mm-hmm. Kate.
Hi, I'm Kate Lally. I was also one of the founding members, I guess, of this caucus. And my connection is as a regional planner. I serve in the legislature in order to try and integrate land use and transportation and the delivery of many other kinds of public services. And I think that public health sets the stage for, we can interweave it with our policy for doing a lot of things much more cost effectively, but at the same time increasing livability, affordability, and health and well-being on every level for Vermonters.
And next, we have a very special member of our advisor to our steering committee, Dan Olson from the Vermont Public Health Association. And he's all things Zoom and pizza and a lot more than that. If you'd like to share a little about yourself, Dan.
Yeah, sure. So hi, everybody. I'm hiding back here with the computer and the Zoom controls. So again, Dan Olson, Executive Director of the Vermont Public Health Association. We provide administrative and educational support for this caucus. And one thing I'm really excited about, we're partnering with UVM's legislative intern programs here. Yes, I'm guessing some of you are familiar with that program. We have a fantastic intern named Sarah Keller, and she's helping us do some legislative bill tracking this year. So you'll see a handout. If you don't have one, you can get one before you leave. I believe they're on the table there. You'll see 2 stacks of paper. That printout is good, but it's also being updated all the time. So there's a link on that sheet of paper to the Vermont Public Health Association's website, where we have an ongoing bill tracker for all public health related legislation. So Please think of that as a resource, and also public health is very broad, what fits into public health, what doesn't. If you feel like there's a bill that's missing from that list that should be on it, please just let me know. And again, very much thanks to Sarah, who can't be here because she's in class here at Fox meetings. But also, one of our focuses is mentorship and working with students. Through that, we have a connection with Middlebury College and through connection with Middlebury that we identified as covered for today's first session. Pam Berenbaum. I'm gonna let Pam introduce herself, but I just wanted to say we were really deliberate at talking with this first session about the business case for investing in public health. There is, most of the time, we're talking about the human health impacts and the importance for constituents. But there is a equally compelling importance, and I think increasingly important to some legislation's perspective of the financial impact of public health. Investing in public health is a good investment. Regardless of the health benefits and how Pam's going to share with us from that perspective, some of her knowledge. So Pam, I'm going to, if there's anything else on this committee, I think we can turn it over to Pam.
Hey, thank you, Dan. I really appreciate the opportunity to be here. Actually, it's exciting to be the State House and not have it be like a school field trip. All grown up. And I appreciate this invitation. I also really appreciate the work of this caucus and of honestly all the state legislators, because I know that it's a difficult job and most people have other jobs on top of this job. So just, giving you all props for sure. So the way I came to be here, I do work at Middlebury College right now in our global health program. I'm really not an academic. I don't even know why I'm there. I really identify as a public health professional, and that's how I spent most of my career. After public health graduate school, I worked mostly in health economics and statistics. And I worked with the military, I worked in state government for the health department. I've worked in consulting, I've worked with nonprofits, so I've been in a lot of different sectors. And my longest sort of stint in public health was at the Vermont Department of Health in the epidemiology field unit. So I was an infectious disease epidemiologist there, and I specifically worked on pandemic and all hazards preparedness and weapons of mass destruction preparedness as well. So I think that's enough about me. I'd love to dive in. And I know in some cases I'll be preaching to the choir here, but if you're wondering why I have this bizarre collection of pictures on the first slide, it's because investing in public health is really no different than other forms of investment that we do all the time, or prevention. So like sort of starting at the top left, we encourage everyone to, invest in the stock market. That's where your retirement stuff is. You could lose everything, and when you invest in public health, you're going to get it back. Not true of the stock market, even though that's the sort of foundation of our economy. If a hillside is on fire, put out the fire before it becomes an inferno, and destroys the town. Like, you have to get on these things early. And if your roof is starting to look old, you need to replace the roof. If you've got a small hole in the roof, fix the hole before the entire thing caves in and then your entire house is destroyed. This is really the public health approach to doing things. Prevent problems from getting worse, prevent problems from starting, make an investment that you're going to get back eventually. So in this talk today, shoot, my little clicker's not working. Thank you. Now it's working. Okay. So I'm going to talk about the role of social determinants of health. I'm going to connect health to the economy and talk about returns on investment in public health. I'm also going to lift up aspects of legislation that I think are important from this perspective. What I'm not going to do today is hammer you over the head with a lot of data. Trust me that everything that I'm saying, I'm happy to provide you with all sorts of literature that's got all the data, but I think just talking about statistics would not make for a really interesting presentation. Okay, so I think everyone here probably knows that in the United States overall, compared to other wealthy parliamentary capitalist democracies, we spend way more on health and we don't live nearly as long or as well. So we're really an outlier. And this is obviously at the national level. And all of that, everything that we're spending there on this graph, 90% of that, so now I'm in the yellow box on this slide, 90% of all of our health expenditures nationally is on medical care. 90%. But we actually know from research that's been repeated over and over again that healthcare only explains 20% of actual health outcomes. Some estimates are as low as. So when you look at why does one person live a long time and another person doesn't, the healthcare they got is only 10 to 20% of that answer. The other 80 to 90% are things like the environmental quality. What kind of house do you live in? Are you educated? Do you live in poverty? Do you have an abusive family or don't you? Do you use tobacco? Do you exercise? Do you drink? This is what really explains differences in health and life expectancy. So these non-medical factors that determine health are what we call the social determinants of health. And you can see the categories on this slide. Economic stability, neighborhood and physical environment, education, food, community and social context, and then the healthcare system. Specifically, can you access it? Is it of good quality? And so public health is really about addressing those social determinants of health. And we do some stuff with healthcare as well. But a true public health approach combines work in all these other domains. That's the only way to make a population healthy. And just for some examples of how powerful the social determinants of health are, this is a map of the Boston subway. Most of you have probably ridden it. And if you get off at Fenway, there's a 2% chance you have diabetes. If you get off at Maverick or Dudley, your chance of having diabetes is 11%. This is all in one city. Diabetes, as you probably know, is a major cause of disability and pain and suffering and early death. And zip code also determines your life expectancy. So this is Kansas City, Missouri. There are two neighborhoods, Blue Hills and Armour Hills. They are a 10-minute drive apart. They're a little over 3 miles apart. The difference in life expectancy is 14 years.
Wow.
And a 10-minute drive. You know, and that has nothing to do with the healthcare system or how good hospitals are. That is all social determinants of health talking. And I need to stop here and lift up this incredible book by Vermont author Kenneth Cadell. It's called Gather. If anyone in this room has not read this book yet, please read this book. It talks about, in a very interconnected way, a lot of the social determinants of health as we follow this boy who lives in poverty. His mother is addicted to opioids. The house is falling down around them. The car is breaking down. It's about so many things I put in red font in the box. It's an incredible, incredible book. So I just have to put in a plug.
Did you know he was here yesterday?
No.
He was wonderful. Incredible.
Yes, and he's deservedly, his book is getting all sorts of awards and I love this book. So I would have read another 2,000 pages, honestly. But I really think, honestly, for legislators, it's a great book to read. And what I really like about the book is that it, you know, the boy in the book could potentially be someone that a lot of people might want to dismiss. You know, a boy living in poverty, addicted mother, getting bad grades, you know, the type of kid that we might want to write off. And the book really convinces us why we can't do that. And anyways, just love the book. Okay, so, and I'm sorry that this is hard for you guys to see, but this is from a Massachusetts report called Healthy People, Healthy Economy, which is sort of a harbinger of things to come in this talk. And the bar that's going up on the left is medical expenditures, healthcare, and all. So that's an increase. The bars that are going down is a decrease in spending, and the decrease is in all the social determinants of health. You know, and so when you don't pay for those things, then your medical expenditures go up, and it's just that simple. As an example, people that are housing insecure are more likely to have chronic health conditions. They're more likely to postpone getting medical treatment until it's whatever problem they have is too far advanced. I'm going to advance my own slides because I can't see that far. So a lack of housing and health problems are one of those things that becomes a downward spiral. You know, as people slide further and further into insecurity, into poverty, they don't have housing, their health gets worse and worse. So And I know that everyone in this room knows that we've got a real housing crisis in this state. And it's also becoming a public health crisis. You all probably saw the Vermont Digger report on the number of people that have died from homelessness in the state. Another issue that I want to bring up is that of transportation. So about 10 years ago, I did a study with a really terrific student in Addison County. And we interviewed every executive director of every nonprofit in Addison County. And there was only one topic that they all said was a problem for getting people to the services, and it was transportation. So we are a rural state. Addison County is very rural. No matter what social service this nonprofit was providing, if they could change anything, they would beg for more transportation. So transportation is a major determinant of health, especially in a rural area. And especially if we want to contain healthcare costs and prevent problems and put out fires when they're small, people need to be able to go to the doctor at the first sign that something is wrong. But people have a lot of, especially older people sometimes, they might have lost the ability to drive, or they don't feel comfortable driving at night or in the snow. They postpone care, and then their care becomes a lot more expensive. Then they might lose their independence, and then they become more dependent on state services. So rural transportation is incredibly important. I just want to give a shout out to Tri-Valley Transit, which does a great job. That they don't cover the whole state, but they provide an amazing level of service, thousands of rides, and a lot of volunteer drivers as well. So it's an example of a nonprofit providing an essential public health service, in part using volunteer labor. And one of the things I'll be talking about is more use of volunteers in the state.
Can I just ask a clarifying question about that?
Sure.
So is it 100% volunteer, or like in our community,
No.
we have volunteers who are reimbursed 60-something cents a mile for driving? So they
They
volunteer,
are-
but they are paid for their time. in a sense.
They are paid,
Yeah,
but not all of them frankly need to be.
okay,
And I don't think anyone's ever asked them. So I have a friend that drives for Tri-Valley Transit.
Yeah.
He's retired because he's independently wealthy.
yeah,
And the state pays him, or someone pays him
Yeah.
60 cents per mile.
right.
While he's driving his, like $40,000 car. And I don't think anyone ever asked him, hey, do you really need
Yeah.
this reimbursement?
Yeah.
So I think there's a lot of potential there. Expand a program like that and have people volunteer their time, like pure volunteer. So, a lot of times the reason why people don't do things is because they're never asked, honestly. Thank you for the question. And also, I hope we'll have time for questions afterwards, but if anyone has a question, please stop me, raise your hand. If I don't see your hand in the air, just call my name. My name is Pam. So just shout it out. Or hey, you, which I also respond to. Okay. So I promised you I was not going to hit you over the head with data, and I'm not going to. But I'm just here to tell you that there is a wealth of data that demonstrates in monetary terms the return on investment in public health. A lot of the literature is actually from the United Kingdom, where they have nationalized health insurance, basically the equivalent to like Medicare for all. So, they really do need to defend the system to their taxpayers. And the evidence is abundant. I'll show you on the next slide some price comparisons of disease screenings, catching disease early versus paying to treat it later, if it's even treatable. Great returns on investment there. And at a global level, there's also a lot of information from the World Health Organization, from the World Bank, the International Monetary Fund. And a lot of this attention on the connection between health and the economy and returns on investment is actually from the HIV/AIDS crisis. Now some of you might know people that have AIDS or are HIV positive, and now it's a chronic disease because we've got great medicines for it. Before then, the World Bank was making all sorts of loans and grants to countries, especially in sub-Saharan Africa, for economic development, and the workforce just kept dying because AIDS was mostly hitting people in their 20s, 30s, and 40s. So the World Bank realized you cannot do economic development without investing in population health. Because if you don't have a healthy workforce, you don't have an economy and you don't have tax-paying citizens. And so there's lots of data. I can provide you with studies. If you want to see them, I'll give you my email or Dan can connect you to me. Okay, so here's some actual estimates of return on investment. So these are ratios of monetary savings to costs. child safety fees, 3,900%, fluoridation, mental health. You know, all these are all classic public health programs. These aren't even really getting into the social determinants of health. These are just classic public health interventions to prevent disease, prevent injury. And, you know, I wish my retirement funds were doing as well as this, you know, I mean, you really can't argue with these numbers. And again, this is tons of information on this, which I'm happy to share. Here's an example from California. They have a tobacco control program. Now, of course, California is a gigantic state. If they withdrew from the United States, they would have the 9th largest economy in the world, by the way. So not a little bit different from Vermont, but nonetheless, they cut their smoking rate in half for adult smoking. They saved 1 million lives, and they saved over $816 billion in healthcare costs. 1 million lives, 816 billion. That's I triple checked this number. It really is billion with B. So, you know, there you have it. So nonetheless, even though all the data and evidence points to the fact that investing in public health does pay off, there are a lot of political problems with trying to get that done. And I'm not going to go through all of them, but if you just focus on the pictures, so we start at the bottom. We're happy as a society to do, you know, a coronary artery bypass surgeries at great expense on some guy who's then going to be out of work. Who knows if he'll even be able to return to work, you know, at enormous expense. And his portion of that bill might even, you know, jeopardize his future. Medical bills are the number one cause of personal bankruptcy in this country. You know, and then if that was the guy, you know, if we build parks, we build bike lines, you know, there's all these ways to make communities healthier. Yet for some reason, we hesitate to invest in those things, to keep this guy healthy and off the operating table. And this is just sort of a chronic short-sightedness that culturally we seem to have, and that does pose an obstacle to legislators. And a lot of the problem, I think, in trying to spend big on public health is what we call the wrong pocket problem. So this is where one agency might pay for a program, but then another agency sees the benefits or the savings. So that's the belief. So if you're familiar with economics, this is sort of the notion of negative externalities. But I want to challenge whether or not that's really true. So for instance, somebody might say, why should the state invest in preventive health for the elderly if they're all on Medicare? So isn't that the federal government, you know, that's paying for that? Why should we invest in keeping older people healthy at the get-go? And what I'm here to argue is that it's still worth it, even if they're on Medicare. First of all, many of the older people in this state, and most states, are also on Medicaid, which we're paying for. So already, you know, that is state budget. We want older people to stay physically active. We want them going out, you know, shopping, eating in restaurants, contributing to the economy. We want them healthy so that they might choose to work, or they might choose to volunteer. I know a lot of elderly folks, you know, and they're active, you know, when they're healthy, they are active. They are contributing to a better Vermont. We also need our elders to be healthy and well for family stability. We have a lot of grandchildren that depend on their grandparents to take care of them. And as you all know, we also have a real substance use disorder problem in this state. We have a lot of parents that are not able to care for their kids because their lives are falling apart. So we need grandparents. We also just need elderly people because they are wise and they have so much to teach us and they're part of our community. So, you know, great. Awesome that we have Medicare. That's fantastic. But keeping older people well and healthy benefits all of us in many, many other ways. So an example here of such a program is SASH, which some of you might be familiar with. This is just these are screenshots from their website, and they've had all sorts of successes. You know, managing diabetes, reducing high blood pressure, all sorts of things. Not to mention all the social benefits, of getting folks together. So, that's a program that does not cost a lot. There's volunteer components. There's a lot of connections to other community organizations, big payoffs. So what I'm really trying to convince you all is that health and economic development are really connected. And I'm throwing education in there as well. And I know that last year, this caucus had a presentation about education funding, but all education, health, and economic development, these are all gears that are turning each other. Educated people know how to navigate their own healthcare. They are health literate. They're healthier adults. That means they can work. They can be financially independent. They pay taxes. And the better economic development we have, the stronger we can make our schools. And these things just keep churning and reinforcing each other. Okay, so it's possible, I believe, to grow health and the economic situation in Vermont at the same time. And in fact, they are really dependent on each other. And when we make healthy communities that are safe and enjoyable to live in, where people can take advantage of health promoting opportunities, we attract people to the state. We need a way for young families to come here and be able to find a house that they can afford. It's a whole separate issue. But through affordable homes, the healthy environment, good schools, people are going to want to stay here and raise kids here and, ultimately pay taxes. We want to keep adults in the workforce as long as possible. We don't want people dropping out of the workforce to take care of ill family members. That is just a lose-lose situation. And we also, and here's where I'm going to go out and go a little crazy here. We need some sensible tax structures. Can we please just tax the wealthy? I mean, there are, second, third, fourth, fifth homes here, and I work at an elite college and there are a lot of 1%ers at the college. And I can assure you that literally while they're in college, their parents will buy a fifth home in Vermont. And if you think that they are, bestowing all of their wealth on the economy, they're not, because they bring their private chef with them when they're here. Why are we not taxing the heck out of these people? I don't understand. But I'm not running for office here, so I can say this. And I'm happy to say those things. But I also want to make the point that we really do need a different tax structure because the middle class is disappearing, which I think everyone here also probably knows. So this graph shows, so the middle income folks are the yellow line. Upper income people are increasing, middle income people are decreasing. Same thing with wealth. So the first graph is income, the second one is wealth. And our entire tax code is basically structured on having the middle class bear most of the tax burden, because historically there were so many middle class, that's what most Americans were, that it made sense for them to carry the biggest tax burden. Middle class is completely disappearing. And so things do need to change. And the wealthy have gotten a lot wealthier and they can afford to pay a little bit more. If any of you in this room are fabulously wealthy, I still maintain that you can pay more. Sorry. That said, there's also a lot of low cost or mutual aid ways to improve population health. Just, so for instance, we have in my county, Addison County, we have Addison County Fair and Field Days, which is your usual, kind of 4-H club, funnel cakes, sketchy amusement rides. It's a great thing. And, the health department can come there, set up a booth. I have volunteered for the open door clinic, just taking people's blood pressures, I mean, these are low cost, easy ways to show up, show people that we care, and in partnership with local nonprofits. Workplace wellness is a really important thing as well. There's a lot of big companies. There's a Fortune 300 company 6 miles from my house, Collins Aerospace, and they actually do a reasonable job of having workplace wellness, but a lot of workplaces could do more to do screenings, a lot of health promoting things that they pay for, because honestly, when their workers are healthy, they benefit. And they just need to be asked, maybe given some tools. Again, volunteer drivers. Volunteer drivers to take people to medical appointments. It's a huge, important thing that we can ask people to do. I would love to see health literacy drop-in sessions. So we already have like lay people that, at the library, there's like a free clinic where someone can help you prepare your taxes. Or we've got the assisters, we used to call them navigators, to find you health insurance. So just trained lay people. And so many people are discharged from the hospital or they're given medical instructions. And to be honest, they don't really understand them. A lot of people don't know basics about nutrition. And that's something that community health workers, lay people that receive some training can easily do in their communities. And there's no reason why we can't do that. And every low income country around the world relies on community health workers. If they can do it, so can we. Also, faith-based communities can do amazing things. Actually, the best models for this are actually Black churches in the United States. They are incredible partners for public health. Our demographics in the state, we don't have a lot of Black churches, but they are a model. They hold health education seminars. They help debunk misinformation with their congregants. They hold health pressure or blood pressure screenings, other health screenings in conjunction with local health departments. They have support groups for people with chronic conditions to keep people on track with what they need to do. And they've had partnerships with the National Cancer Institute, health departments for a lot of different diseases. And there are a lot of people that they don't trust the Department of Health and they don't trust state government, but they trust their minister and they trust the people in their congregation. And these are really important community places where health promotion and support for people that need it can take place. Yes. Did you have a question?
No, I was just thinking, you might want to think about the.
Oh, I'm so sorry.
I'm sure people have some great questions.
Okay. This ends when at 1?
Can we go to 1 or till 12:55?
Most people have to head out around.
Yeah, we have a
here.
committee. Okay.
Yeah, we should wrap by 12:55.
Okay. Well, then let me wrap up by saying this is actually kind of where I wanted to end. So the most important thing for new public health initiatives, and there's a bunch of great legislation, that's already on the walls, but future real initiatives need to collect data. They need to be modernized. The most important thing is to collaborate at the local community level. There's no reason why the state has to pay for all public health. We can do it in collaboration with community-based organizations. We also need to hold our partners accountable. If we try something that doesn't work, throw it away. Try something new. Collect the information, be accountable. I have lots of great examples of what states have done that I'll be happy to share at some point. And there's some really great legislation already out there. The VTPHA website has a lot of it. And a lot of it is low-hanging fruit. Stuff that doesn't even cost anything. No cell phones in schools. We know they're really detrimental.
We have a bill for that.
Yes, that's what I'm talking about. Exactly. Anything to promote housing, anything to eliminate gun violence. You don't have to spend a thing. Just don't let these major public health threats continue. Invest in schools. So, okay, I will stop right there. Like I said, I'm happy to provide all sorts of literature and data and examples of what other states have done in terms of sort of collaborative community-based partnerships. So just let me know. Dan knows how to contact me.
I'm sorry, if I may.
Yes, please.
If you slide back, do you have examples of legislation on your slides? Because that's what I'm coming here, like the Vermont State Legislature for a process. And that's one of the things that we want to come out of this caucus is to understand how we can put that lens of public health on all kinds of legislation that is coming through our building. In places that would surprise us. So that's sort of like your presentation was interesting. Those who work in health sort of know this stuff, but I want to surprise the people that don't work in health and how that what the work is doing is affecting health. That's sort of how I'm.
So you mean like other states that have,
No, here, well, if you have examples from other states are great. Yeah.
I have examples from other states and I've got some, there's so many bills actually right now that I couldn't really go through them all.
The
but-
idea of accountability, you know, or analysis. How do we analyze a bill that's in transportation for health or in the box or anywhere in our building and the impact on health because we don't see it.
Right. Well, first of all, there's a massive amount of literature, again, which can be, you know, you can find. And I would say a great place to really get a whole picture is from community health needs assessments that nonprofit hospitals are all required to do. And they survey their clientele and they find out what those barriers are. And I actually worked on the community health needs assessment for Porter Medical Center in 2021. And getting people to come back for follow-up appointments is incredibly difficult in a rural county that's also the most rapidly aging county in the state. You know, and people just wait too long. But hospitals and doctors' offices, they know what all of these barriers are. And they can be surveyed, they can be interviewed for the local evidence. And then we've got all the national evidence and what other states have done to sort of back that up. But it's the kind of information that is not often captured because it crosses so many different sectors. But people that work like interviewing these nonprofit executive directors was very revealing. You know, you wouldn't think that transportation would be such an issue, and it is. And you know, and I don't think that we need to launch some sort of gigantic survey at great expense. You know, with very little money, a student and I, we produced this report that revealed a lot. And please, like, you know, the legislature should absolutely go to UVM, go to Middlebury College, go to Vermont State. You know, there's some great students that are really motivated that can do some of this work.
Are you thinking like, because one thing we've talked about, which I think Leslie mentioned, is just having, you know, what does that like lens look like and economically? And it makes me think what you're talking about is when we put together a new policy or contemplate some new legislation, if we look or use the social determinants of health or even just one at a time, like transportation, like this new program, how are people going to access it? Like that could be a way to start approaching the spectrum of legislation that exists and seeing the impact on public health.
Yeah, and honestly, there's no substitute for the local picture. You know, that's really where a lot of the evidence can come in. And where a lot of the volunteer labor and a lot of the collaborations are going to happen. So, but I think in adopting a public health framework, I think there's also, you have to understand, like, the benefits can be hard to measure, or they might not be seen immediately, you know? And that's where monetizing the benefits can really torpedo the ship, you know, because these things are all, you can't parse them out. Like you can't just look at a transportation system and say, oh, well, this is expensive, because it's saving money in other realms. It just really honestly needs to be articulated.
And going off of that too, I'm totally averse to just using money as a metric for success and all, and it's really annoying. But about halfway through on one of your slides, there was, you know, that chart of what the payoff was economically, and those were national analyses. And I'm curious if I don't know what went into making those or getting those numbers, but I am curious, like, of course, I imagine they have a ton more funding than we do, but are there pieces of that where we could calculate better at the state level? Like, could we equip our joint fiscal office, for example, with whatever tools those data organizations use to do better measurements, because I know in a floor speech, when you're trying to convince somebody, let's pass this bill, like usually numbers help at least a little bit, especially
Right.
for people who don't immediately want to agree with you.
Yes, I'd have to, and doing economic evaluation, it depends what you want to count.
Mhm.
So there's a lot of different methodologies for doing that.
Yeah.
So I have some state examples, and I'm happy to, like, Dan, you can send everyone the slides if you want to. Do some examples. You really have to drill down and see, what they counted.
Yeah.
But I would also, yeah, I mean, you guys are facing pressures that I'm not really aware of and can probably never understand. But also something like, for instance, tobacco cessation.
Mhm.
Why do we need to reinvent that wheel? Like, why would we need to reprove, like, smoking looks the same in Vermont as it does anywhere else?
Mhm.
You know what I mean? Like, I think that I would rather make the argument of, like, let's not waste money
Mhm.
proving what is already known and has been demonstrated over and over again everywhere. So I guess that's the way I kind of push back. Is
Yeah.
like, we don't need to prove that gravity works in Vermont the
Yeah.
same as it does in New Hampshire, I mean, there's some of these public health savings over the long term are so well documented. And they work the exact same here, really where I would say, if you want to sort of like really monetize things and really drill down,
Mhm.
I think you need to get at the sort of rural, elderly and transportation issues
Mhm.
and the housing stuff. Like, that's what makes the Vermont situation different
Mm.
than a lot of
Yeah.
other jurisdictions that have demonstrated savings.
Yeah.
Like, we can't just say, oh, we're gonna build this wonderful dialysis facility or something. How are people gonna get there?
Mhm.
Like, that's always the challenge here. And so that's really where I would say, if you want to sort of drill down and collect data, it has to be
Yeah.
on what makes Vermont unique.
Yeah, thank you. That's really helpful.
If I may, I'm wondering in your research, have you come across a checklist or some kind of exemplar, structure, framework that can be applied to legislation? Checklist. Yes, yeah, got that, missing that, need that we can then apply.
I have not found such a sort of like a rubric for what makes a good piece of legislation.
With regard to public health, because that's what I would love to see come out of this in my imagination.
Well, honestly, the real gold standard are those local community partnerships.
Yeah.
Because then it's not just all coming out of state coffers, and it's really locally oriented. And that sort of, the importance of a local viewpoint is true even for global health at an international level.
Sure.
And like the blueprint for health, by the way, please vote for the governor's, there's a stopgap measure in the governor's budget. Blueprint for health is a great example of collaboration at the local level. And that's, I think, also politically, when people see what's going on in their own community and it involves their local organizations, it helps with the optics of what the state government wants to do.
Sure.
Afraid. Yes, no.
Thank you so much.
Well, I hope this helped. I'm not really sure. And there's a lot more.
Great art for us, because I love the same things.
Great,
We'll make sure to get the. It's been cool.
great.
Slide it.
And you're welcome to them. And I have some examples of state partnerships, like multi-stakeholder collaborations. So we didn't get to those, but if Dan can send the slides around and you can see examples.
And